Hi, this is Roger Green, host of the Surfing the MASH Tsunami podcast. This week, we're offering 5 conversations from episode 4, our review of MASLD Epidemiology and Disease Burden with Zobair Younossi, plus, from the vault, an epidemiology discussion from back in 2022. Initially, this conversation focuses on cost effectiveness. I start off asking how economics of treating MASH stack up against hypercholesterolemia at the birth of statins in the 80s, when the medical benefit was clear but the economic was harder to gauge or to accept. Zobair proceeds to describe the process by which cost effectiveness of drugs is measured, computation of quality adjusted life years, or QALYs, and how different countries vary in the level of QALYs they consider cost effective. He also notes that within the U.S., at least, we may be willing to accept 5 times greater cost per QALY for some disease than the $50,000 standard for most others. He also points out that cost effectiveness grows as new therapeutic options induce price competition into a market. Louise Campbell shares the specific U.S. cost numbers from Zobair's article, which she terms frightening, particularly given the rate of growth in the disease and the society's lack of efficacy in shifting the curve on prevalence and progression. Zobair responds by saying that one goal of the article was to create awareness that regular surveillance of diabetic patients for MASLD could have a significant economic impact in the U.S. As the conversation winds down, Jorn Schattenberg comments that this is all a team effort, and Zobair hardly agrees. Zobair Younossi has spent decades building a knowledge base that is a significant part of how the world looks at MASLD patient dynamics and trends today. This discussion encapsulates some of that wisdom in the context of winter 2024. It intrigues while it educates. So just sit back, listen, enjoy, learn, and when you're done, join our dialogue in the LinkedIn discussion group.
Roger Green.
So Zobair, just follow up quickly on one small part of that. Going back a long, long time ago, I remember one of the discussions about aggressive treatment of hypercholesterolemia back in the 80s and 90s being that the number of patients that would benefit at a cost per patient up against what you'd have to spend to really eradicate the problem didn't make sense economically using the metrics people used at that point in time, because the cost for every case that advanced to, say, to a cardiovascular event versus how many people you actually had to treat for cholesterol to get there, those numbers were more balanced. Here, my guess is that if you're talking about 1.8% of the population with MASH cirrhosis, that the cost of treating those 1.8 million people is so exceptional on an annual basis that even if you had to surveil 100 million people to get there, the numbers would actually work out. Do I have that roughly right in my mind? Does the scale work that way?
Zobair Younossi.
Well, yeah, I think what you need to do after establishing efficacy and effectiveness of any drug or any treatment regimen, you have to establish cost effectiveness. And cost effectiveness of the drug would be established based on value equation, which means that it is not only about outcome. We have surrogates of long-term outcome here. We use fibrosis and resolution of MASH as a surrogate of long-term mortality, liver-related mortality. But it's the cost of the drug and cost of the disease over the quality of those years that actually are added because of the use of the drug. So we use something called cost efficiency assessment or cost utility assessment, where you take all of these things into consideration. Now, I can tell you that when you look at, say, the analysis that was done by ICER in the United States for the 2 drugs that were out there, the resmetirom from Madrigal and then obeticholic acid, that's not currently being considered for NASH. At least the ICER analysis and then subsequent analysis suggested that if the drug is priced well, and the efficacy data that we're seeing currently is going to also be seen in the real-world setting, that this drug will be cost-effective. So from a society perspective, it's, are you meeting, if you're using a drug, are you meeting what's called the willingness to pay threshold for that country? So the willingness to pay for this country is that in the United States, in general, $50,000 for each additional quality-adjusted life years is accepted as a cost effectiveness. Now, that you have to remember that even in the United States, there are diseases that actually even much higher threshold has been accepted. $200,000 to $250,000 per QALY, for example, for some cancers is acceptable. Now, that may not be the case in another country like in India or even in UK. The thresholds are lower there. So when you're actually looking at the drug approval in terms of efficacy and safety, then at some point one has to do economic analysis and show that from a societal perspective that is actually acceptable. Now, that's also different than sort of a budgetary perspective, from a payer's perspective. So everyone has to do their own modeling, and I think it will happen. If you remember in the old days of hepatitis C, it wasn't actually cost effective to treat patients with the drugs that we had. But as the efficacy increased, safety increased, and drug prices fell, it is no doubt that the treatment of hepatitis C patients are going to be cost effective. So we're sort of this first steps towards that goal. But I have no doubt that even with the drugs that are at the sort of verge of getting approved, that we will have cost effectiveness from a societal perspective. And then we have to convince our payers, which is much more complicated in the United States because there are so many different types of payers, to convince them that for their population that they have under their plans, that the drug will save lives, will save complications of cirrhosis that are quite costly, or liver transplantation. So that has to be done, and it's something that all of us, including Jorn and others, are playing a part in.
Louise Campbell.
I was amazed by this piece of work, and congratulations to both Zobair and Linda Henry, who I think was the co-author with you on this. And it makes frightening reading if you break it down into just its figures. And when Zobair was talking there about the cost, there's a section here that one of the studies that you use, that NAFLD amongst patients with type 2 diabetes in the US could lead to 5.8 billion 20-year cost, 65,000 liver transplants, 1.37 million cardiovascular-related deaths, and 812,000 liver-related deaths. These are frightening figures, and we're nowhere near looking at how we're going to stop the Titanic from moving. We're not really spending the time in prevention, earlier diagnosis, earlier assessment for poor liver health before it leads to some of these complications. So just picking through the document was fascinating. And from a patient's perspective, it's not just the patient who suffers, it's the quality of life of the person, the people around that patient, trying to support them, the extra days they take off from work to support that patient. If I look at the Australian models, moving around the country to get FibroScan in limited areas, that takes an awful lot of resource. So I'm hoping that this sort of epidemiological data now really pushes the WHO to really focus on giving it NCD status, because that will help focus it in low middle income countries where some of this is a real problem. So it's a great piece of work. It is frightening. It's not quite Halloween yet, but it's an early piece. It was startling.
You're right. I mean, the purpose of that was for us is to just highlight the fact that the burden is important. So when you look at patients with diabetes, no one will question their risk for eye disease, for retinopathy, or kidney disease, or cardiovascular disease. However, the liver disease has been and continues to be ignored. And I think that is really the point to make, is that when you look at this group of patients, they can actually drive this important outcome that could be much more costly from a societal perspective than even other complications of diabetes. And this is not to replace one complication with another complication or rank them, but just to raise awareness that when you're doing your annual check and there is, even in primary care setting here, if a patient has diabetes, there is no doubt that you're going to be sent for a retinopathy check, an eye check, or get a creatinine assessment for a kidney check. But no one is really thinking about, well, maybe I should actually do a FibroScan or some sort of a test to see what the liver status is to the diabetic patient with that high number. And I think that's the point of this, is to just make sure that we assess those patients who are at risk to see if they're considered quote-unquote high-risk MASH or high-risk MASLD or not. And that's done with the non-invasive tests. And very easy to do. Even if you don't have a FibroScan, you certainly can do a FIB4, which is available by just simple blood test and some demographic data. And I have to tell you that looking at some primary practices where I practice, you don't even have those labs done so that you can calculate the FIB4 by a lot of the practices. So there's got to be a more awareness even at that level. So we're hoping that all of us together can actually help stakeholders. And I think you're absolutely right. When we talk about indirect costs or intangible costs of this disease, we're not actually calculating the cost to the family and to others. And this is really the purpose of this, not to scare people, but to actually raise the reality that this disease is going to become become even more prominent if we don't deal with it now.
Jörn Schattenberg.
That's a very important point. And I think it's both towards, the payers, the regulators, the colleagues, where you say the people that are responsible for implementing a FIP4 to be able to use it as suggested by the guidelines and actually refer patients, getting in the mindset to be ready. And I think the work that you and your team have been doing around the numbers really support that effort.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put those in the review section of the page from which you downloaded this conversation, or send an email to me, questions@surfingmash.com. We'll be back next week to discuss what new information or product to expect in NIT space in 2024. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.